Good evening, ladies and gentlemen. It's a great pleasure to be with you this evening for this 30-minute live question and answer webinar. My name is Marc Evans. I'm a diabetologist, an academic clinician based here in Cardiff. And I have two cases from my recent clinics to present to you and to discuss some of the pertinent issues that have arisen from both of these particular patients. Session will be about 30 minutes long, and I'm happy, of course, to take questions related to these cases and, of course, the discussion points that have arisen from them. So we'll move to our first case. Now, both of these cases are relatively complicated individuals with type 2 diabetes. The first is a lady called Elsie. She's 74 years of age, diagnosed with type 2 diabetes when she was just about 60, so about 14 years ago. She'd always been overweight and a HbA1c target above target. She'd been admitted to hospital about 3 years previously with a positive troponin level, and a coronary angiogram at that time demonstrated the very typical atherosclerotic distribution of 3-vessel coronary disease with no surgically amenable lesions or anything that could potentially be addressed with percutaneous angioplasty. Over the last 12 months or so, she'd become increasingly lethargic, more short of breath, particularly on more strenuous exertion. Current medication includes atorvastatin, metformin, gliclazide, bisoprolol, lisinopril, and sitagliptin. If we move on to examination results and her data. So at the clinic appointment, her BMI was 33, with an HbA1c elevated at 9.1% or 73 millimole per mole, so I apologize for that typo. Blood pressure was 144/88, with a total cholesterol of 3.5 and LDL cholesterol of 1.9. Evidence of albuminuria with an urinary albumin to creatinine ratio of 12.2 milligram per millimole, along with a GFR of 44. So in essence, we have an elderly lady with established coronary artery disease, suboptimal control of her type 2 diabetes, with evidence of CKD stage 3B with proteinuria in the form of albuminuria. So clearly this lady has an elevated cardiovascular risk, complicated, of course, by the recent development of symptoms in the form of breathlessness. So in terms of the key clinical issues, we've already discussed these. This is a lady with poor glucose control, who is most definitely overweight, established coronary artery disease, evidence of chronic kidney disease, albuminuria, and possibly heart failure based on her clinical presentation. And of course, heart failure in this case would not be surprising in that up to a third of people with type 2 diabetes can have evidence of heart failure. And this lady obviously has a predisposition to the development of heart failure in that she has previously suffered with a myocardial infarction and has diffuse 3-vessel coronary disease. So with this in mind, in terms of other investigations that might indeed be useful in this case, I would certainly be thinking here about the need for an echocardiogram to look at the left ventricular function, as well as atrial dimensions and right ventricular function. An ECG might be useful, as might a BNP. In terms of diagnosing heart failure in type 2 diabetes, there are a variety of issues. Current guidance here in the UK is that a BNP of over 400 would support a diagnosis of heart failure, while a BNP of between 100 and 400 is not necessarily diagnostic, while a BNP of under 100 would be fairly reassuring in terms of no evidence of heart failure. Now, in diabetes, as in other situations, there are a variety of considerations around interpreting a BNP. A BNP may be artificially elevated if someone is on a DPP-4 inhibitor, as DPP-4 is an enzyme for the degradation of BNP. So BNP is a substrate for DPP4. Thus, use of a DPP4 inhibitor can actually result in false positive elevations of BNP. Equally, if you have patients on an ACE inhibitor, on a diuretic, or with very poor glucose control with associated osmotic diuresis, this can result in artificial lowering of the BNP level, resulting in a false negative. These factors really do need to be considered when interpreting BNP data in relation to making a diagnosis of heart failure. Thus, an echo in this case would also be very useful. An echocardiogram here with evidence of impaired left ventricular function would support diagnosis of heart failure, while evidence of either atrial dilatation or increased right ventricular filling pressure or right ventricular stiffness would be indicative of what's called HFpEF, or heart failure with preserved ejection fraction. So currently we subdivide heart failure really on the basis of HFrEF, heart failure with reduced ejection fraction, and heart failure with preserved ejection fraction being the other subclassification. So in terms of the third point with respect to this lady's case, how would we go about managing this individual's glucose control? So clearly we need to try to optimize things, as she is 74 and has fairly poor glucose control. Now, based on the most recent ADA EASD update in terms of choice of glucose lowering therapy, in view of the fact this lady has established coronary artery disease and chronic kidney disease, as exemplified by her GFR and her albuminuria, then we would really be thinking about using either an SGLT2 inhibitor with outcome evidence, and that would include dapagliflozin, empagliflozin, and of course canagliflozin, or alternatively a GLP-1 receptor agonist, again with evidence of outcome benefit, such as semaglutide, liraglutide, or dulaglutide. From this lady's perspective, I think my approach here might be to consider switching out the DPP-4 inhibitor and introducing an SGLT2 inhibitor based on the discussion points that we've already had, or possibly even adding in an SGLT2 inhibitor, as I would certainly be wondering about the possibility of heart failure, which is indeed what we were thinking of, as well as the evidence of chronic kidney disease, particularly the reduced GFR. The data with respect to the different classes of drugs has certainly demonstrated a reduction in progression of GFR and decline, and indeed a reduction in degree of albuminuria with the SGLT2 inhibitors, as seen in the Credence study, as also seen in the EMPA-REG study, as also seen in the DECLARE-TIMI 58 study. We've also seen outcome benefit in terms of reduced cardiovascular mortality, particularly in the EMPA-REG trial. And from the GLP-1 receptor agonist perspective, we have CKD outcome benefit, but this is largely driven by a reduction in albuminuria as opposed to an effect on GFR per se. Equally, in these studies, we've seen effects on body weight reduction, which would be very useful for this lady, particularly in terms of her symptoms and long term. One of the things to consider, of course, in people who are particularly elderly with diabetes is the need to remember that HbA1c's may be artificially elevated in relation to a blood glucose level. As with increasing age, there is an increase in glycation rate coupled with increased red cell survival, all of which means that you can have an HbA1c that is actually higher for a given glucose level than for younger people. So that's something to bear in mind, particularly around concerns in relation to hypoglycemia. But from this particular lady's case, I think the approach here would be either the addition of an SGLT2 inhibitor, or possibly replacing the DPP-4 inhibitor with an SGLT2 inhibitor. but I think the addition of an SGLT2 inhibitor would certainly be the approach based on current evidence and indeed the current national, international consensus on treating glucose in type 2 diabetes. So we move on to our second case. And Andrew is a 65-year-old gentleman, and he was diagnosed with type 2 diabetes relatively short time ago, about 2 years ago. He's overweight, and his HbA1c had never been particularly in control. He's hypertensive and also gets a little breathless on modest exertion, but has no other medical history of note. Gave up smoking 7 years ago, and his clinical examination is unremarkable. Current medication, atorvastatin, metformin, and lisinopril. If we look at his values, he has an HbA1c that's a little suboptimal at 8%, 63 millimole per mole, with a BMI of 33. His cholesterol is pretty good at 3.5 millimole per litre. Albumin to creatinine ratio is 6.1 milligram per millimole. So that is elevated. Bear in mind that the normal threshold would be less than 3. So he has albuminuria, his GFR of 68, and he has a BNP of 440. So in this situation, having done a BNP, this would support the potential diagnosis here of heart failure. So undoubtedly, this gentleman's breathlessness may be related to either HFpEF or HFrEF. Based on his smoking history, one might think that he might have some element of HFpEF consequent upon right ventricular strain, etc. So if we move on to our discussion points, what's the optimal approach to managing this gentleman's glucose? Well, I think this gentleman's glucose control certainly needs intensifying. His HbA1c of 8% is very typical of the average HbA1c for patients receiving metformin monotherapy. And this indicates the issue that we have discussed on many occasions at various meetings around clinical and therapeutic inertia and the delay to initiate or intensify treatment when appropriate. In terms of our considerations for glucose-lowering therapy in this individual's case, I think much as we saw in the first case, an SGLT2 inhibitor would really be our treatment of choice here, driven by the fact that he has albuminuria. He also has evidence of probable heart failure, undoubtedly based on his BNP level. And again, referring back to the ADA-EASD consensus position statement, I think that these features taken together would drive us towards an SGLT2 inhibitor as opposed to any other treatment, such as a GLP-1 receptor agonist, for example. Which therapies would we not use and why? I think I would try to avoid here sulfonylurea if at all possible, largely based around the hypoglycemia risk and also the potential for weight gain. I certainly would be trying to avoid a TZD such as pioglitazone based around issues in relation to fluid retention and the diagnosis that we've been discussing of potential heart failure in this gentleman's case. Exogenous insulin therapy is often something that is discussed as being used early within the natural history of type 2 diabetes, and I would agree that initiation of insulin in a timely fashion is actually very important with respect to addressing the issue of clinical inertia. We can see that many people are delayed from insulin initiation for a variety of issues, and this can expose people to elevated glucose levels, contributing to the contributing to an increased risk of both micro and macrovascular endpoints. That being said, I probably would not look to use insulin in this gentleman's case right at this particular moment in time, largely because we do have evidence of other treatment options in this particular case. Now, this gentleman's GFR is 68, which would imply that we have potential glucose-lowering efficacy with the SGLT2 inhibitor. So from the perspective of lowering glucose, an SGLT2 inhibitor would be a very good treatment option. Now, if we go back to the earlier case of Elsie, what you will notice is that the GFR here is only 44. Now, this raises questions as to the glucose-lowering efficacy of an SGLT2 inhibitor in this particular situation. As we know from the clinical trial data, that with GFR less than 45, there is diminishing glucose-lowering efficacy. However, we also know that the effects of an SGLT2 inhibitor in terms of outcome are independent of the glucose-lowering effects. And indeed, the ADA-EASD consensus statement states that we should be thinking of an SGLT2 inhibitor or a GLP-1 receptor agonist irrespective of glucose levels or glucose-lowering effects from the perspective of outcome benefit. Now, that's not really the issue here, as we should see sufficient glucose-lowering efficacy. However, in the earlier case, this is something that we may need to consider, particularly in relation to how we manage that lady's glucose levels. Because the SGLT2 inhibitor may not produce sufficient enough glucose-lowering efficacy in her case, at which point we might need to think of additionally adding in a GLP-1 receptor agonist with evidence, such as semaglutide, and in this case, replacing the sitagliptin. So these are the sort of considerations that make treatment choice quite complex in terms of managing glucose in type 2 diabetes. We not only have to think of efficacy, but we also need to bear in mind the outcome data from the heart failure, renal, and cardiovascular and mortality perspectives. In this gentleman's case, what further investigations may be useful? Well, I think undoubtedly you'd all agree with me here that an echo would be very useful to further investigate this potential heart failure diagnosis. While based on his smoking history, a chest x-ray, as well as some pulmonary function tests, may also help us get a further handle or insight into the breathlessness that he's describing. I hope those two short cases have provided you with some insights and some consideration. So thank you very much.